Okay, so that's the first slide meeting the new year. So this is the washing cytology for left ureter. So it's a washing urine cytology. So usually for the washing cytology, we have a lot of normal like fragments of urothelium. For this case, it is very obvious that we we seen these fragments of highly atypical cells. Some are in single cells, some in the fragment. And the cells show enlarged nucleus with really high NC ratio. So there is only very scant cytoplasm in the cells. The chromatin pattern, it does not show hyperchromasia, but it shows this hypochromatic pattern with these ground glass type of chromatin. So it is sometimes you will see this pattern in about, I would say, about 15% of urothelial carcinoma. So the most important feature is the high NC ratio and the polymorphism. The patient has been diagnosed with high-grade urothelial carcinoma in the bladder, also in the ureter, and the patient, I guess, he or she refused to do the radical surgery, so they choose to use the laser to ablate the lesion in the ureter, but it keeps recur. So this is, I think, his or her third time of the specimen, but this tumor keeps coming back. So apparently, he needs to have a complete resection. Otherwise, it would just keep coming back and coming back. So in this specimen, we see most of the cells are tumor cell, but we also see some are benign umbrella cell. So you can see this is low NC ratio, multinucleation, and this is benign. In contrast, these cells are high-grade urothelial carcinoma. So you see high NC ratio, nuclear polymorphism, and the hypochromatic chromatin pattern. So the second specimen is in pleural effusion. On low power, you can see these tight cell ball with very hyperchromatic nucleus, so it looks very blue. And this is a big aggregates of cells. Usually we see this finding. This is so-called cannonball pattern that we would think about the patient might be a patient of breast cancer, and this is likely the metastatic breast cancer. So indeed, the patient is a breast cancer patient, and these are metastatic breast cancer. So this is one of the most typical presentation of breast cancer metastasized in the pleural cavity. So in the cell block preparation, we still see a lot of these cell ball pattern. So these specimen can be used to perform extra staining for ER/PR HER2, because sometimes the clinician needs the data for these recurrence patient. So the next specimen, this is from pleural effusion as well. I'm sorry, this is from ascites of a 50-year-old male. So on low power, we see inflammation, mesothelial cells, and they were scattered single highly atypical cell with gigantic nucleus and some nucleoli over here. So the patient has a history of pancreas cancer. So in this type of specimen, sometimes it's quite difficult to identify the tumor cell because in the inflammatory process, the reactive mesothelial cells can look quite atypical. So some of these dots, for example, like the one over here, I think it's quite difficult to determine if these are tumor cells. I think these are probably benign mesothelial cell, and sometimes reactive mesothelial cell can have mitosis. So this one looks benign. This is a mitosis, but we cannot determine what is this coming from. Is this a mesothelial cell histiocytes, or it is a tumor cell? But in this area, I actually did not see any very convincing cluster of cells that we can call adenocarcinoma. However, this is on the dot. In the pancreas, we are very well recognize that it can have a low-grade feature. However, these tie aggregate with three-dimensional architecture, and you can see the mucin production in the cytoplasm. So these very bland-looking clusters are actually cancer cell metastasized to the pleura cavity. And these larger cells are actually more like reactive type, either histiocyte or mesothelial cells. So these are metastatic adeno, and these are reactive cells. So this is important that you realize what is the original tumor and what you are looking for. So these can be sometimes quite difficult. Yeah, so I guess some of these dots, it's very difficult to tell. I guess these are probably just reactive cells, not tumor cell. And this one is atypical, but still very different from the cancer cell that we see. But this is definitely metastatic adenocarcinoma. Okay, so for this type of specimen, when you do screening, it is sometimes you need to pay attention to these very bland looking, but with the mucin production, these cell cluster is more in the line with the tumor cell. Otherwise, these, because of the binucleation, these could probably just reactive histiocyte or something like that. So you need to dot, you need to highlight these cells. Okay. So the next specimen, the patient has a history of gastric cancer. This is ascites. So again, I think this is very difficult. We see these single cells. It does not show very apparent like signaling ring cell pattern. You didn't see any mucin production in the cytoplasm. So some of the cells show a little bit vacuolation in the cytoplasm. And this is very, very difficult to determine if these are reactive mesothelium or these are metastatic, poorly differentiated adenocarcinoma arising from the stomach. Based on the morphology, I think most of these cells are reactive mesothelium or histiocyte. I'm not very convinced that there are adenocarcinoma here in the specimen, but because the patient also had a cell block you will do a MOC31. So in this cell block, again, you see, I think most of the cells with the foamy cytoplasm, these are histiocyte. Some with more dense cytoplasm, these are mesothelial cells. And they all look like single cells. They can have sometimes quite prominent nucleoli, but it does not against, it can be a reactive process. So in this situation, I think immunohistochemistry is very, very useful. So we would do a MOC31 on these specimen, and my suspicion is that these are negative. So with the immunohistochemistry, we can downgrade it from atypical to negative. Yeah. So next specimen, this is from pleura effusion. Again, the patient has a history of pancreas cancer. So in this specimen, these highlighted area, there were only a few. They were very convinced to be adenocarcinoma. I think. These are probably just reactive. This one is quite suspicious because it's three-dimensional. I think this one is convincing for adenocarcinoma because you see this three-dimensional tight cluster with a luminal border, and within this cluster, the cells show prominent polymorphism with one very big nucleus. Next to it, smaller, and it's 4 times bigger than the smaller one. And it is very tight. And you see here, there are a little bit of mucin over here. So this one is very convincing that it is a metastatic adenocarcinoma. So this one is uncertain, and this one could be adenocarcinoma. So you see there is a signaling cell pattern with some vacuole inside the cytoplasm pushing the nucleus to the periphery, and right below it there is another atypical cell with irregular nucleus. So it is very three-dimensional, and this is a very tight cluster. So this one is convincing for adenocarcinoma. Yeah, I think this one is also convincing for adenocarcinoma. It's three-dimensional, and it shows prominent nucleoli in this three-dimensional tight cluster. So again, for pancreatic adenocarcinoma, sometimes it's very difficult to do the screening because usually the tumor cells are quite scant and the morphology is very bland looking. So it is important that you can identify these key features, including three-dimensional architecture, mucin production in the cytoplasm, so and the cellular polymorphism. So again, this is a bigger cell, smaller cells, and there are some mucin vacuole in the cytoplasm. So this is positive. The other specimens are much easier. So this is the patient with lung cancer. So this is metastatic lung adenocarcinoma in the pleura cavity, and this is a recurrence case. The patient has already been confirmed with the history. Another specimen with primary lung cancer metastasized to the pleura effusion. So these are way more easy than the pancreas, and we think these basically multiple cases every day. So this is again another recurrence adenocarcinoma in the pleural cavity from the lung. And occasionally you will see something not so common in the body fluid cytology. So this is from ascites. The patient had a past history of high-grade endometrial adenocarcinoma. In this specimen, we see a lot of single cells, but these single cells are definitely malignant because first, the nucleus is highly enlarged. The nucleoli is almost as big as the adjacent lymphocyte, and the nucleus membrane is very irregular. So these single cells are positive, malignant cells. They are not reactive mesothelium or histiocyte. It is very uncommon that we see single cell in the endometrial cancer, but in this case, this is not the first specimen that we received. I think she has multiple specimens, and we have confirmed these cells are positive for POX8 before. So this is positive for adenocarcinoma, and because of POX8 expression, this is from the patient's previous history of high-grade endometrial adenocarcinoma, which has developed this high-grade transformation. Another patient from the pleural effusion, and this patient had a history of rectal cancer and with peritoneal carcinomatosis. So when you develop peritoneal carcinomatosis, there's a chance that these tumor cells can also go upper to the pleural cavity. So here are scanned positive cells. Again, because it's from the GI tract, the morphology can be quite similar to the pancreas cancer. So you see this tight cluster with a luminal border and with nuclear polymorphism within this cell cluster. And this is also very three-dimensional. So in this specimen, they are very scant. The tumor cells are very scant. Again, this is three-dimensional with a luminal border. So this is also positive for adenocarcinoma. And because of the history, it is compatible with the patient's prior history of rectal cancer. So the last case today is pap smear. So the patient has been confirmed with carcinosarcoma from an endometrial polyp. So she visits our hospital for definite surgical treatment. So first of all, the patient has been underwent D&C at the other hospital. So it is likely you can see some endometrial element inside the pap smear. And because the patient had endometrial lesion, it is also very common to see endometrial stromal cell shedding in the specimen. It can be either from shedding or from the prior D&C process. In these specimen, we also see some glandular cells. So the glandular cells had a different morphology than the stromal cells. The stromal cells has a very high NC ratio and it's usually very small and very tight. So it can look like a very prominent hyperchromatic crowded group in the smear. But the glandular cells has cellular arrangement for epithelial glandular component. So here you see this is a gland, and they are prominent like cytoplasm with a little bit bubble. So this is glandular cell. Again, this is also a glandular cell, but this one looks more atypical than the prior cluster. So first of all, you can see there are some infiltration of PAM within the cytoplasm of these cells. So this is called phagocytosis. So you see this, you realize this is a glandular cell. And the phagocytosis phenomenon can come from either endocervical or endometrium, but it is more commonly that you can see from the endometrium. The second thing that you see, the cell is three-dimensional. The cell cluster is three-dimensional, and you see some of the cells show prominent nucleolus. So this is consistent with atypical glandular cells. So we see one cluster of a typical glandular cell, and we didn't see anything else. So the presence of atypical glandular cells, the specificity actually is not very high. It can indicate either a benign endometrial lesion such as a polyp, or it can indicate the patient might develop some malignancy arising from the endometrium. In this case, we realized from her previous biopsy in the other hospital that she had a high-grade malignancy, a carcinosarcoma, but we only see these one atypical glandular cell component, and that's it. So we cannot determine anything. We can just report it as a typical glandular cell, possibly arising from the endometrium. However, the patient has now to have this endometrial lesion, and she will receive complete surgery in our hospital. So for this specimen, we call the atypical glandular cell. This is for today.